Welcome to our weekly case capsule. This is a case of dysphagia. This 21-year-old female patient came with dysphagia to solids and liquids. Since 8 months, increased since 3 months. She actually came she was referred for endoscopy. Endoscopy showed a dilated esophagus with stasis of food and water and a tight lower esophageal sphincter. We aspirated all that out and gave a good wash, even with some Ryle's tube placed in the mid esophagus. And then when we went back in, we could see that the LES was tight. The most important thing in such a area is to check for any malignancy if it was an older patient above 70 especially. This is a youngster, a 21-year-old. You don't expect it. So, but still, it's our duty to check the fundus and the OG junction. There was no growth. So this indicates that it's a motility disorder, most likely Achalasia cardia. So this patient underwent esophageal manometry, and this is what it showed. There were high pressures, and this is the normal pressure wave. This is a high resolution video manometry, and this is how the regular pressure wave looks like. This is the peristaltic wave, which crosses like this. If you see here the pressures, the blue and green are low pressures, and as it goes up, high pressures, pink and black. And here, if the upper esophageal sphincter is this area, lower esophageal sphincter is this area. And when the food bolus or the whatever the bolus comes here, the lower esophageal sphincter relaxes. And with this relaxation, we calculate the integrated relaxation pressure, which is 27 here. Anything above 15 is abnormal. It's Achalasia cardia, especially if there is loss of this peristaltic wave. And here you can see some bizarre waves, which is like just high pressurization. It's not even a wave. And this, I'll tell you more about it. So these two things, loss of this peristaltic wave and not an inability to relax the LES sphincter. If you see here, the sphincter is not relaxing. It's completely there. Whereas here you can see it has become green, low pressure. This is a diagnosis of Achalasia cardia. And here the problem is this esophagus dilates. Why does it dilate? Because this LES doesn't relax. And what is the pathophysiology? The myenteric plexus, because of some inflammation, it could be a virus, it could be genetic, it could be some environmental factors. We don't know which one, but all in all, it is end stage kind of a condition, which happens because this inhibitory ganglion cells are lost and neurotransmitter inhibition is decreased, but there is an imbalance and more stimulatory response happens and it goes into contraction, the lower esophageal sphincter. And over time, this is the first thing which happens. And the next thing which happens is the dilated esophagus and loss of peristalsis. And what are the tests which we do other than the endoscopy? A time barium swallow is a wonderful test. Here, if you see, this barium swallow is done, and after 5 minutes, we have to take another X-ray. Or this is an oblique view where we can see this barium is not draining, it's only a trickle, and this is like a bird beak appearance. And after, usually in seconds, the barium should cross into the stomach. Just seconds, even a fraction of seconds. So, but here, if you see after 5 minutes, there is no passage of the barium stays in the esophagus. This is a diagnostic test. And high resolution video, of course, malignancies also can produce a similar pattern. So it's very important to make sure that it's not malignancy. And type 1, type 2, and type 3 achalasia is based on manometry. What difference does it make? It helps us in the different management, and the amount of myotomy which we do and all is different for each, but it's a manometric differentiation. It's not a clinical differentiation, except in type 3, they may have chest pain whenever they have contractions. They have spastic contractions in type 3, which can have chest pain. Type 1 is like, there is absolutely no contractions going on here. It's zero and low pressures. Type 2 is high pressure. This is the only difference between these two. Whereas type 3, there are spastic contractions. You can see the dark pink area, which is not peristaltic, non-peristaltic contractions. These are the different treatment for Achalasia cardia. Let's say that it's a really a patient who is fit for anesthesia and all that. Easiest thing to do is pneumatic dilatation. It still works, but the cut or the tear of the muscle fibers will not be controlled, and we should be careful with that. This is a Rigiflex dilator which we use. Over the wire it goes, and you can do it under fluoroscopy guidance. These are the two procedures where myotomy is done. This is for peroral endoscopic myotomy and laparoscopic Heller's myotomy, which is the gold standard, which we can also combine with a partial wrap fundoplication, because we are lowering, we are actually, making sure the LES is relaxed. It makes sense to do a partial wrap. So here is what, this is the Heller's myotomy. Peroral endoscopic myotomy, we create a tunnel actually in the submucosal space, and the scope passes through that, and we dissect the myotomy. We do the myotomy entirely in the submucosal plane, so there's no breach of mucosa, only one cut here above, like we allow some space and start the myotomy, and then we clip it when we come out. So entirely the procedure is done endoscopically. It's really, really a boon to the patient, which, saves them from a major procedure. And we avoid the sling fibers so that there's no reflux episode. Our patients are pretty okay without reflux. And this is how the steps go. Here a submucosal cushion is created, then you enter the tunnel and go through this. This is the mucosa, this is the muscle, and we're going in the submucosal plane. And then we do the cut here, the myotomy. And this is the Poem armamentarium. We have a various of different knives which we can use, and different needles, coir graspers. And this is a basic knife we use, which is a triangular tip TT knife, TTJ knife. And this is the electrocautery unit, which is specialized and very sensitive for this procedure with all the various settings. And here is our patient. We've been doing this Poem for the past 4 or 5 years, and the patients are doing well. Here we inject, lift, and then we are creating the cushion. That's the TT knife where we are making the cut. Very superficially, we can have vessels which we coagulate with the coir grasper. And here we start 12 to 15 centimeters above the OG junction. This is in the esophagus. Now we're entering the blue. The blue color is because of indigo carmine, which we mix with the normal saline to give us the color, and the muscular plane will be white, and only the submucosa will light up as blue. And now we've entered the tunnel, and you can see that is the tunnel where we are now, coagulating the vessels, then cutting through the tunnel to reach the OG junction. As it's all endoscopic, we can easily feed the patient quickly and discharge them in 48 hours, even in 24 hours. Actually, we just watch over them for 24 hours. Here you can see us doing the myotomy. We are doing a full thickness myotomy from this length. You can see this is the circular muscles being cut, and this is the longitudinal muscles below that. Usually, even if we cut the circular muscles, the longitudinal will get just played up. So you can see a bit of the mediastinum there. Now we are closing. We finished the tunnel, and you can see us closing with clips. And these hemo clips are it just stays there, and it will fall off once it is healed. And it's a very elegant procedure. And then immediately the patient has a very good inability to swallow. Yeah, this is the manometry after, I think we did it after a while. Here, I think we did it after 6 months. Here you can see that the LES is now relaxed. Thank you very much. I hope you enjoyed our video.